Share screen. Go here to chapter 15. We're going to spend two days in chapter 15. So this, so I'll be able to start building review quiz because I know chapter 15 is where we're going to cut it off for the exam on Wednesday. The thing is we will have lab Wednesday. Sorry, hope you hadn't made plans because we're going to do A&A. We're going to do A&A slides this week. And you'll need probably Wednesday to review the slides you make on Monday. That's usually the way the lab goes. It takes you Monday to make the slides, and then we come back on Wednesday and review them and get a feel for what it is to diagnose A&A. And that's going to be one of your few times that you get to look at those slides. Okay, we save them. They're going to be put in a little Petri dish and put in the fridge. And you can review them for the final, but look for the final immunology final last second exam to have slides, okay? Because we will put these slides on there and have you identify these patterns. Good enough, right?
Like pictures
or the real slides, the ones you do Monday and look at Wednesday, they'll come back and I'll just grab up a few and put them on microscopes. I think we'll do it that way. I don't know if I really want to have you roaming around the room, but we might. I think y'all can stay spread out and move around to like look at scopes and look at stations for the midterm. So it'll be a practical like midterm, second exam, be a final for lab. Usually those are before finals week. So it's like the week before finals that we have that to close up lab. And then we have the big final, during finals week. I don't do lab finals during lab finals week. Does that make sense? I know we're already talking about finals. Isn't that something? Yay, you're supposed to be like, that's exciting. Yeah. All right, so we're going to spend a couple of days because we're going to talk a lot about the mechanism to autoimmunity at the beginning today. And then we'll slowly get into some of the disorders and then we'll finish those up on Monday. So it's our normal linked chapter. So it's not like hey, I'm going to spend 2 days on a chapter that was double the size. So we're going to slow down just a little bit with autoimmunity and make sure we got a good grasp of all the autoimmunities. And I say A&A because A&A is one of those where the slides do pop up. They come back on the board and you'll see pictures and they'll say, what is this pattern or what autoimmunity would be linked to this pattern? And with A&As, we're talking about anti-nuclear antibodies is what we're talking about with A&As. Okay, so that's the test you'll be doing. But the pattern could be more than one, okay? So anybody that's had an autoimmunity, it's really hard to make a definitive diagnosis. There's some that will say, well, you have this symptom or you have this antibody, so we know you have this, like Hashimoto's with thyroidism, hypothyroidism. Systemic lupus, the first one we're going to get to, maybe we'll get into it today. We'll start it today for sure. Is one of those, it's a kind of a vague diagnosis. They kind of have an indicator that may say this or that or the other. But if you ever talk to somebody that has lupus, a lot of it's based on what's going on with them, okay? And some of these tests that we're doing. So it's really hard to nail down systemic lupus erythematosus. But others can be linked to a certain antibody or certain damage or certain biopsies, okay? So we can biopsy tissue and help diagnose some of these too. So I'm getting a clap from Heather down here. Okay, good. Is that the finals that we're talking finals already? Who is this?
The fact it's working.
Oh, it's working. Okay. Yay.
Yeah.
All right. So the chapter overview, mechanism of autoimmunity is where we'll start first. So this is going to be a review. You remember when I said, we'd always be lecturing early on in the semester and go, oh, this linked to autoimmunity. This is linked to, or if this breaks down, it's linked to autoimmunity. Or if this doesn't happen, it's linked to autoimmunity. So we're going to review that first. We're going to talk about immunological tolerance. Talk about genetic factors and how those play a role, and then environmental factors and how they play a role. So it's still a lot of unknown when it comes to autoimmune diseases. like, why did I get it? Why didn't, you know, we think of genetics, and one of the things in the chapter is that your identical twin doesn't have it, but you have it. So it maybe not always linked to genetics. Then we'll start with the list of the autoimmunes that you should be aware of, but we'll go through systemic autoimmune diseases first, and that includes our lupus, our rheumatoid arthritis. We have granulomatous, and we got associated lab testing with all those, and you're going to start that next week with ANA. We have organ-specific autoimmune diseases. We have humoral and cell-mediated immune responses directed against this. We're going to finish with organ-specific, and that's where we have some examples, especially with, my wife is one of those organ-specific autoimmune diseases, so we get to use her as an example. Okay, so now the chapter. Autoimmune diseases, humoral and cell-mediated immune responses directed where? Back at our self. So our self-antigens have now become the focus of antibodies, okay? We've produced our antibodies against ourself. And these could be already there. The antigens could be, all of a sudden they have a little change, and now they're more antigenic all of a sudden, or there's breakdown in the normal immune response. Maybe we shifted away from a T helper 1 and went more to a T helper 2. We talked about that a little bit. So these do cause tissue and organ damage. We know that. So it can be like rheumatoid arthritis, it could be in the joints. It could be systemic lupus, where it's kind of an overall feel. Anybody that has hypothyroidism, we don't really know what, could be the end result of that, because we go both ways. Somebody might say, well, I've got too much weight gain. I'm losing weight. I'm sensitive to cold. I'm not sensitive to cold. I hurt all the time. When you live with somebody that has autoimmune diseases, you hear all these. You hear all these different symptoms. You hear different responses to environmental stimulus. I'm just tired. So a lot of patients come into the doctor, I'm fatigued, I'm tired. And as the lab, we will start screening. So there will be screening tests that we will start with. It might be the SED rate just to start off with. Do they have inflammation? Then it might be specific tests, like let's run a thyroid stimulating hormone. I run several of those out of the ER. Just here they are. Then it might get even more specific with that, where we have a whole list of ANAs, getting patterns of the anti-nuclear antibodies, rheumatoid, or the RA factors. So we have this whole list of things for lab testing that you may or may not connect with lab tests, right? We just don't always connect screening for autoimmunity or chasing this in the normal sense of medical care, where we think it's just, we're just going to see if you're infected or if you got an infection, or if you're suffering from a virus or a bacterial infection. It may be an autoimmune. So what the reason we have autoimmune is the loss of self-tolerance. So we're going to review our mechanism for central and peripheral tolerance. That's where we're going to spend a lot of our time today. So this loss of self-tolerance, the ability of the immune system to accept self-antigens has decreased. So the immune system now is not so receptive to self-antigens. And we know there's a programming, we know there's a regulation, we know there is a maturation, if you want to call it, of certain cells that kind of desensitize them, or maybe kill, right? When we talk about apoptosis, about getting rid of cells that may be too strong in a response. So we have that, and we've already talked about how that happens. Hopefully you can remember. If you can't, it'll be a good review for you coming up. So here is the mechanism, and sorry I cut off peripheral, but this is central and peripheral tolerance. So this is the chart from your text. So you have this, And we know this already. We know where central for T cell is thymus, right? We know central for B cells is bone marrow. So we have both of these sitting here. And that is our central mechanism of making sure these cells are not what? Going to get aggressive for an antigen. They're not going to over respond. Then we have peripheral. So once the T cell gets out of the thymus, it goes into the lymph nodes and spleen. So there's another, I call it kind of like massaging the T cell. It's like, okay, we're just going to kind of down regulate you or slow your response. So we're going to teach you how to be more receptive to the self-antigens. And then in the peripheral here for B cells, lymph nodes and spleen too. So all of this programming that we have to keep our own cells from attacking ourselves and causing damage is all part of this mechanism. So we have a really good review slide for that to show that at the end result at the bottom, right, escape self-reactive cells. So, and that's what happens. We get a B cell that escapes all of this checks and balances. We get a T helper cell that escapes the checks and balances. We get a cytotoxic T. So we get our T4s and our T8s and our B cells in the lymphocytes that escape all the natural programming or getting rid of the ones that we don't want so that we're not getting cell death of the overreactive ones, right? Remember we had negative selection where if a T cell was too strong on reacting to the antigen, there was a mechanism to halt that cell, right? Halt it and kill it inside the thymus so that it didn't escape the thymus. Same thing with the B cells in the bone marrow. All right, so that is all part of your text. If you're with me, it's 234. So let's look at negative selection. Let's just review that. Occurs when both the immature and double positive, remember that double positive had a CD4 and a CD8 on the T cell itself in the cortex of the thymus. And then we had the more mature single positive, then they go to either single CD4 for the helper or the CD8 for the cytotoxic. Does that sound familiar? Y'all are at least there with me, right? Hopefully we did our job early in immunology and you're there. You do know that the distinctions with CD4 and 8. I think you do. I've heard y'all talk a little bit about that. During this process, some of the self-reactive CD4 T helper cells are not deleted, but instead differentiate into the Tregs. And these cells can specifically inhibit the immune response to self-antigens. That's what we hope happens, okay? We're hoping that happens. Similarly, B cells mature in the bone marrow with these receptors having strong affinity for self-antigens, and they're eliminated by apoptosis. Some self-reactive B cells are not deleted, rather they are stimulated to rearrange their immunoglobulin genes so that the B cell receptors are no longer antigen specific. This process is known as receptor editing. So this is what's going on. B cells then possess receptors that are only weakly recognized self-antigens, induced to downregulate the expression of the receptors to develop a specific state of unresponsiveness called an anergy. Okay, so that's what we're hoping happens. So that's the normal process up in the central area, the little top part of your table there, figure 15.1. Thus, there are several ways in the central tolerance BNCs are achieved. It's not totally effective, so we look for peripheral help. Right? So they move out into the peripheral level. If that first level of regulation doesn't happen, the lymphocytes then recognize self-antigens in the secondary lymphoid organs. If it happens there, they're rendered incapable of reacting with those antigens. Okay, so this is the second step down, where all of a sudden you get a cell out in the peripheral and they react to self-antigens and they are then regulated to be destroyed. We don't want that happening. So that's the second step. So that's 2 steps of help that your body naturally does to keep these cells from recognizing self-antigens to a strong overreaction. So in some individuals, to finish this up, it says self-tolerance can fail. So autoimmunity is when self-tolerance fails. It happens, autoimmunity can arise. Autoimmune disease is thought to be caused by complex interactions between genetics, that's the first one we're going to talk about, exposure to the environment, and that's where a lot of people are focusing. They think that the environmental influences has increased the amount of autoimmunity. And then defects in the immune regulation. All right, we good? Think so? Is this refreshing to see that we actually know a little bit about this? You can recognize these names. You can kind of understand where we are. We at least have that down, right? Shouldn't be a surprise on this. So again, genetics, environmental factors, which one weighs more than the other? So let's look at genetics. I don't know. I know we have a room full. We have 3 guys in here versus 1, 2, 3, 4, 5, 6, 7, 8, 9, 9 to 3. So a third, right, of guys, or is that whatever, a quarter? Females. Females develop autoimmunity at a higher rate than males, to the fact that I think it gave a percentage here, I remember reading it, that women are 2.7 times more likely to acquire an autoimmune disease. This is over on 236. 2.7 times more likely. 78% of the patients with autoimmune disorders are female. Okay. So this is definitely, should be very interesting. I definitely have a wife that has autoimmune. I think you have classmates with autoimmune that have undergone treatment. There's always, it seems like every so many years, I have a lupus patient in my class. So we have experienced this, and the thing is that most of the female cases are early, young. This isn't 60 and 80-year-old females developing autoimmune. This is 20, 30-year-olds developing autoimmunes. So what triggers that? Could it be hormones, female hormones, tissue injury, and release of self-antigens? That's one way we know that can happen. So could hormones lead to increase? Yes. I think estrogen is labeled as an increaser. I think that was over, where's my hormonals? Hormonal influence. I think there was estrogen in here. Yes, right here. The effects of hormone. Estrogen tends to direct the immune system in favor of the type 2 helper cell. Remember when we first started talking about that push to the helper 2 instead of the helper 1? Estrogen seems to do that, resulting in more B cell activation and antibody production. Whereas androgens, that would be like the male, is that the male hormonals? Androgens, y'all know what androgens are? Is that testosterone be one of the androgens? They favor the type 1 helper cell with activation of the CD8, or is there androgen? What are androgens? Somebody help me out. We kind of hormones and hormones, right? What are androgens? Somebody's got their laptop open. Typing away there. Kathy helping me. Okay. or Zoom. Zoom, y'all can help out.
Are a group of hormones that play a role in male traits and reproductive activity.
Male traits. Okay, that's what I was thinking, but I wanted to make sure. Prolactin for females, a hormone produced during breast milk for pregnant women, nursing women, can stimulate both humoral and cell-mediated immune responses. And the stimulatory effects of female hormones may place women at a greater risk of developing autoimmune disease. So I think we're seeing that, right? So anybody think of anything that could be hormonal? Not that y'all naturally aren't hormonal, right? Producing hormones and doing your normal thing. What has increased over the last 40 years or so?
GMOs.
Huh?
GMOs.
GMOs, okay, for food, the environmental factors. I was thinking more of a hormonal supplement.
Birth control.
Birth control, right? Birth control. Increase in that. Is that why we're seeing more autoimmunity? Right? Birth control has kind of become one of those, hey, we can stop our normal hormonal cycles by adding different hormones to our intake every day. Could be. There's microbial infections, and we'll talk about some of these where you may, and we've talked some of this in micro, sorry, press on that, but some of these infections that we get can be stimulators or cause tissue damage because of where they end up, the toxins of some of the infections. We're going to cover that today too. And then epigenetic factors, toxins, the GMOs, is it GMOs, right? Foods, drugs, aging, post-translational modifications when it comes to changing the way our DNA derives some of its proteins. So if you look at it, those environmental factors, then you have a genetic susceptible individual. So we can look at their human leukocyte antigens or other genes. And then the loss of immunological tolerance. So we get activation of self-reactive T cells and B cells because of these things. Okay, so all of a sudden our T and B cells decide, you know, that looks different. That self-antigen that I used to recognize as a self-antigen and I didn't attack it, as you age, something happened. That thing changes. Your genes change. All of a sudden, a glycoprotein doesn't look like it used to. And these cells then get active. So that leads to autoimmune disease. So that's what we're going to kind of cover here. Not going to jump through those real quick because I want to spend some time on these. So here is our list. So we're just kind of going to leave this here as our list of where we want to go. Because see, the book just went right through that. The book put one slide up for that. So that's where we're going to spend probably most of the day. Right here between 236 and where systemic lupus pick up, the next page. So we'll spend a little time between this little section here. Because I want you guys to know, I want you guys to have, you know, this is a great 2 page, it's just 2 pages. I mean, it's 2 pages, but it's packed. It's packed with 2 pages of info that gives you the background, I think, of the, you know, as we like to say, the foundation before we jump into each one and start telling you maybe how these happen, and we're going to go through them, and that makes it fun. So fun will come mainly on Monday. Yeah, we'll have a fun lecture on Monday because we'll talk over all the autoimmunes that you've been waiting to hear about. The first is hormonal influence. We've kind of started that off. We kind of covered it already by talking about the female being the most of our patients, 78%. We talk about estrogen. We talk about prolactin with breastfeeding. But this tissue trauma, let's look at that one. So this is the second one on our environmental factors. Tissue trauma and release of cryptic antigens. What is that? So immunological tolerance to self-antigens occurs. We know that. We've already covered that in the thymus and the bone marrow. But some of these self-antigens may be cryptic. Do y'all know what cryptic means? What's cryptic means to some of us? What's a good way of saying cryptic?
Is it like locked? Not open.
Not open, locked, hidden. That's
Yeah.
good. Yeah, hidden message, cryptic message. You got to be kind of, it's hidden within the tissue of the host. So the T and B lymphocytes are shielded from these sequestered antigens, and they're not educated. Y'all know we are educating our B and T cells. That was the word I was looking for earlier. We educate our B and T cells, and they become tolerant to them. So they're not educated to become tolerant, so they're hidden. So they don't have any exposure to that cryptic or that hidden antigen that's there. At a later time in life, inflammation or tissue trauma can cause that antigen to be released and suddenly accessible to the uneducated lymphocytes, triggering an immune response. That makes sense. That should sound like, yeah, I'm almost through with immunology, and that actually makes sense to me, right? Tissue damage could be caused by factors of infection. We just talked about that with a microorganism. Contact to the environmental toxin, or even physical injury with ultraviolet light, okay? Another reason to not hang out in the tanning beds and not to hang outside on the beach without sunscreen, right? This concept has also been referred to as immunologic ignorance and may be responsible for the production of autoantibodies. This happens with like damage to your eye. You have an injury to your eye. All of a sudden you have a response to the eye that's not doing us any good. There's damage, but then there's an autoimmune attack to these antigens in the eye, causing further problems. Autoimmunity to sperm after vasectomy. So we didn't want to leave the guys out here since they were only 22% of the patients, right? So in a vasectomy, all of a sudden you have autoantibodies against sperm due to the injury, autoantibodies to DNA following damage to skin cells from overexposure to UV rays and the sun. So makes sense, hopefully. So we don't think about that. Who would think that we could cause autoimmune attack against ourselves by being out? We talked a little bit about, drinking caffeine and UV light, that repair mechanism. This is more, that's to the DNA. This is more hidden antigens. Okay, damage to the skin releases this antigen. Damage to an eye, damage to a vas deferens when we talk about a vasectomy. Questions on the tissue trauma and this cryptic antigen? The hormonal influence, tissue trauma with release of the cryptic antigens of the uneducated B and T cells. Okay, hopefully that's simple enough. I think you should have that graph. Microbial infections. This is a kind of a little micro review from way back, first part of micro. Been very interested in this, in the autoimmunes. Bacteria, viruses, and other infectious pathogens may trigger autoimmune responses. So we call this, the principal means is the microbes are thought to accomplish this through molecular mimicry. Refers to the fact that many bacterial and viral agents contain antigens that closely resemble the structure of the amino acid sequence of the self antigens. So you get infected, right? There's a response to the infection. We would hope, right? If you get a virus, your body puts an antibody up. But then that antibody now sees a self antigen a little different. So now it responds to it and causes tissue damage. All right? So that should hopefully make sense. That these antigens that were brought in from the external that are infection, that they have so much similarity to our self antigens that the antibody that's produced actually reacts with our self antigens now. The molecular mimicry has been postulated as a mechanism for a number of autoimmune diseases. The best known is our gram-positive strep pyogenes, and that's why I wanted to bring that one in. Because we all know about our group A strep pyogenes, and rheumatic fever. So if it goes untreated, our strep throat, the reason most kids don't get out of the ER with a sore throat without a little antibiotic added to them is because of this. We don't want it to develop into something more serious. It's easy to take care of. It's easy to give a quick treatment of penicillin and get rid of strep pyogenes, get rid of strep throat. If you don't believe me, just get strep throat and you will be very happy when you get to take the penicillin or the ampicillin, and it goes away almost instantaneously because I've had it as an adult and it's so fun. And it was actually a day like this. I showed up in class first lecture, and by the end of the day I could hardly swallow. It was killing me. So I was like, I need something. I was like, I think I have strep throat. Let's do it. Yeah, strep positive. That's a good thing about our working in a hospital, our lab program. We have strep tests. We can quickly do a screen on you for free, and we'll get your strep diagnosis, and we'll say, hey, now you need to go get some penicillin of some kind. And once you take that, like an hour later, your throat's so much better. And by the end of the day, after that, wow. Before I could drive home, I had an hour drive home. I picked it up at the pharmacy. Before I got home, I was already better. That's how quick penicillin can work. It's great. And the end of the strep throat. But don't forget to throw away your toothbrush. It's key. Any of you had strep throat? I don't think we really talked a lot about strep throat and micro, but all right, don't forget your toothbrush, because you just re-expose yourself if you don't keep using that same infected toothbrush again. So that's like the number one advice I can give you is throw away your toothbrush. All right, but that rheumatic fever, okay, affects the joints and the heart, and that's from the strep pyogenes infection. Okay, so that antigen from strep lets the body now starts to go into an autoimmune, and we have symptoms 2 to 4 weeks after infection. And there's an antibody to the M protein of the strep. We're not worried about that in here because it's immunology, right? But it does ring a bell, hopefully. And it cross-reacts in the cardiac myosin. That's cardiac muscle and causing damage to our heart. And that's where we get rheumatic fever, and that's where we get murmurs and all that good stuff, and maybe even a valve replacement later on in life. So it can just go downhill from there. Second way of microbes might trigger autoimmunity is through a bystander effect. I love this. In this mechanism, the microbial organism does not have to share the structural similar antigens to the host, right? So this is not a similarity between the antigen and self-antigen. This is just the things there, right? The microorganism induces a local inflammatory response, recruits leukocytes, stimulates antigen-presenting cells to release their cytokines. All this should sound very familiar, hopefully. Hopefully this is. I hope I haven't gotten to this point and you're like, what are cytokines? What are antigen-presenting cells, right? We should have that by now. So this non-specificity activates T cells. Some of these T cells are activated, may have specificity for the self-antigen. So what we did was just being around, all of a sudden the T cell gets revved up, and that T cell's like, I'm the self-antigen T cell. I'm the one that slipped through. And you just rev me up, and now I'm gonna start attacking that self-antigen just because of another infection. Okay, not that the antigen had anything to do with the self-antigen, just being the bystander. And this is called epitope spreading. This expansion of the immune response to unrelated antigens is also termed epitope spreading. So that's our 2. We have a third. Isn't this fun? Hope it's fun. I know it's not the names, it's not all the problems, but I think we need to start here. It's one we did a 2-day. Thought I'd be making this 3 days, but I think 2 is enough. But I was like, man, we just need to dive into autoimmunity this year. All right, third way. The microorganism might induce an autoimmunity is through superantigens. Yay, we get something really super. Super antigens are produced. These are proteins that are produced by various microbes that have the ability to bind both class 2 and T cell receptors, regardless of their antigen specificity. So this is like, we didn't really need we didn't need a perfect match. We didn't. I'm a super antigen. Examples here are Staphylococcus enterotoxins, cause food poisoning and toxic shock syndrome. So these are the big ones, right? These super antigens can act as potent T cell mitogens in activating a large number of T cells. And anytime we get a large number of T cells, there's different antigen specificities. If some of these T cells possess that self-antigen liking, there's an autoimmune response. Some viruses, including Epstein-Barr virus. We haven't gotten there yet. Has anybody heard of Epstein-Barr before? Infectious mononucleosis, Epstein-Barr virus. Okay, we're getting there. We'll get there. And cytomegalovirus can cause polyclonal activation of the B cells. So not only are we these super antigens revving up T cells, we've got other viral infections that rev up B cells. So definitely can give us problems. We also have microbiota, normal flora in the immune system. The presence of certain microbiota, some normal flora in our bodies, are associated with a greater risk of autoimmune disease. I'm seeing if I can't remember if there was a name of any of this microbiota or not. I just think it just said we did have some. Okay. Questions on that? We doing okay? We just have a couple more to look at, and they're not as fun as the microbial infections, of course. But we do have a couple more. We good? Or y'all just worried about your heme test? Is that all you're worried about? See, I was thinking she was like, not gonna have lecture, y'all were gonna just be focused on studying. I was just gonna come in and just kind of lighten the load, lighten the mood, and then let you go back to seriousness. No? Okay. Because I didn't know. Maybe it was on computer, but I didn't know if y'all were. Was this lecture on new stuff or old stuff today? New stuff. New stuff. So, y'all don't like that, do you? Okay. All right. I try. I kind of learned. I learned that. Yeah, you only do that a few times and everybody starts like, why are we going over new stuff? All right, back to our stuff. Epigenetics and modification of self-antigens. Okay, so this epigenetics refers to the modifications in gene expression that are not caused by changes to the original DNA sequence. So we're not altering the DNA. The alterations, these are stable and can be inherited. They are thought to be triggered by exposure to environmental toxins, ingestion of harmful foods and drugs. So this is where we get our, what we eat. Are we inducing, do we need to be all organic? Do we need to be away from antibiotics from our food sources? Do our chickens need to be, farm raised or out into the fields, and our cows need to be happy? Saw that commercial the other day. Like our milk cows are happy. We put them out in the pasture and they get to eat grass and all that. So it was some milk commercial, right? So harmful food and drugs, and also aging. And we can't do anything about aging. We are getting old. You're getting older as we sit here today. I know I never think that, but pictures tell me different. These factors can induce epigenetic changes. And what that is, remember, we're not changing the DNA. These epigenetics are increasing or decreasing the myelination of the cytosine bases. So modifying histones, causing abnormal regulation of the microRNAs, These modifications result in a change in the level which genes are expressing. They're affecting the ability to transcribe messenger RNA. What that does, it changes the protein. If we know anything about antigens, they're proteins, what drives the mechanism, right? The proteins are things sticking out of the membranes or things that can be picked up as antigenic determinants. So basically what happens is the phenotype of the individual kind of changes, and what we get is an immune system that now sees an imbalance, sees a change, and that self-tolerance is now dwindling. It's a change, right? Like I was educated with this protein, and now that's not the exact protein that I was educated against, so now I'm going to respond. And that's where the self-antigen response comes in. So these changes at the protein level they're post-translational. So these are not genetic. These are influences that lead to changes after. It's not altering the DNA, but it's altering the way the messenger RNA ends up with the protein, with the amino acid sequence. So acetylation, lipidation, citrullination, and glycosylation. So putting sugars, putting lipids, putting acetyl groups on any of this protein that's coming out has changed the self-antigen, and now the antigen presenters and the T cells see that alteration. And one of the examples is with rheumatoid arthritis. Anybody know anybody with rheumatoid arthritis? Debilitating, okay? Joint pain, debilitating rheumatoid arthritis, disfiguring arthritis, okay? So what happens here, glycosylation of the myelin is involved in the pathology of multiple sclerosis. So anybody know anybody with multiple sclerosis, MS? Okay, another. So we'll see these two. We're going to talk about these coming up, rheumatoid arthritis and multiple sclerosis. Okay, so that is a epigenetic change. So toxins, food, and aging, a post-translational modification. So I think that's our main one. So that's our three. Then you have a little section in your book called Interactions Between Factors. And this is all, it says, although the precise etiological of autoimmunity is unknown, right? We really can't pinpoint it. We know there's a lot of factors that influence it. There's much evidence that suggests that this heterogeneous disease entity is caused by complex interactions between genetic and environmental factors. So we'll finish up. We're going to move over to 15.2 just to kind of get an idea. 15.2 is way over here with common anti-nuclear? Is that where we were? Is that where it says to go? 15.2? Doesn't seem right. Oh, it's figure 15.2. That's what we already have up there. Okay. It's just saying it's probably many factors mixed in. It could, we know genetics. We know there's certain markers in genes that make you more susceptible to certain autoimmunes. We know there's environmental influences. We know there's now epigenetic factors, whether we got an infection of a certain virus when we were 12 or we were 15, right? So we know this all can play and all combine to give us these autoimmunes that we'll cover on Monday. Any questions? I just saw Dr. Wall pop around the corner, so I know it's time to wrap up. Any questions on this? So if y'all have any hematology questions, ask Dr. Wall. She'll be in here. No. Yeah, see her between class. No. Good luck on your test. And we'll see you getting the quiz up. Get that opened up sooner than later. As soon as I feel like I got everything in there I want in the quiz. And we'll cover these chapters from last test to through chapter 15. And that's on Wednesday. We will have lab Monday and Wednesday next week for A&A because it's really connected to this material in this chapter 15. All right. You have a great weekend. See you Monday. See you later, Zoom.